Well, we'll go ahead and I think we can get started. I'm not seeing a massive rush to come in the door now. So anyway, welcome and thank you for coming at 4:30 in the afternoon. We're delighted to be here, and we're going to be talking about senior care and housing, and specifically the role of housing in helping to manage the healthcare needs of senior living residents. I just want to start first just to kind of do a little bit of a summary of what we're going to be talking about. I think we're going to be presenting some new data and kind of reacting to it and reflecting on it and what it means for the industry. And the data basically says something that will be of no surprise to anybody in this room, but the senior living population, meaning those in independent living, assisted living, are like a particularly frail, complex care population, more so than ever. They use a lot of healthcare, and there are a lot of organizations now, as a result of a variety of changes that have been made over the last 10 years, that are now at risk for that healthcare spending of the residents in senior living buildings. So this is becoming kind of the utilization of these residents becoming an increasingly important issue to entities that are part of your ecosystem in your markets, like health plans, insurers, hospitals, health systems that are taking risks. So we have to start, as an industry, we have to start to think about what our role is in all of this. And I think a particular interest to me is some new data that we've just released today that shows that about 30% of residents in independent living, 30% of residents in assisted living are enrolled in Medicare Advantage plans today. And we expect that to increase over time. So, we're really excited to talk to you about the opportunity to offer value to these risk holders, to offer value to your organization, to your residents. And I'm really extremely lucky to be here today, to be co-speaking, facilitating this panel. So we have sitting here to my left, Larry Leisure, who's with Chicago Pacific Founders, and Ken Sargarnik, who's with Brandywine Living. And so again, we'll let them tell you a little bit more about their organizations and their perspective and their experience as we go. But first, so I'm just going to lead off with, you're going to be inundated with data, but the first thing that I want to start with is the first part of the analysis that my firm, so I'm with a company called ATI Advisory, and we are a research and consulting firm that's based in Washington, D.C. We do a lot of research on the industry and work with operators who are looking to find ways to integrate with healthcare and coordinate healthcare for their residents. And we asked the question, kind of what is the level of care needs of this population today? So this is 2017 data on the Medicare population, and we created these sort of analytic categories looking at people who are living in housing that doesn't have services attached to it. We call that retirement housing on this slide. Independent living, assisted living, and nursing homes. And the first question that we asked of the data was, what is the level of functional impairment and functional needs and cognitive impairment in these different populations? How do they compare to each other? And I think I'm just going to point out a couple things here, and then let Ken and Larry kind of react to this and tell you a little bit more about their organizations. But I want to one of the things I want to point out in particular is if you look in the assisted living column, and you see that 63.2%. That's the percentage of people who live in assisted living today who need assistance from another person with 2 or more activities of daily living. And so I think everybody in this room probably knows what those are. So I don't have to explain what ADLs are, but bathing, eating, dressing, that kind of thing. 63.2%. And I know Stephen Littlehill's here, so I'm going to feel a little embarrassed when I say you can contradict me later if you disagree with this statement. But I tend to think of the 2+ ADL level of need as being a nursing home level of need. Like when you think about what it takes to be qualified to live in a nursing home and be paid under the Medicaid program, I think of 2+ ADLs as sort of being a proxy for that nursing home level of need. So in my mind, we've got 63.2% of the assisted living facility population today that probably has something like a nursing home level of need, that they would qualify for a nursing home if they were to try to seek Medicaid reimbursement for that. So that's a pretty high percentage. And then the other two things I just want to point out is that, the independent living residents are obviously less, they have less of that really high level of functional decline that represented by the 2+ ADLs. But you see the beginning that kind of twice the rates of like early functional decline and those instrumental activities of daily living, that 40.2%, and then also a doubling of the rate relative to housing without services in the share that have cognitive impairment. So this data comes from a nationally representative sample survey that the CMS does of Medicare beneficiaries every year called the Medicare Current Beneficiary Survey. I just am absolutely kind of fascinated by the degree to which that sort of acuity or frailty, I guess, kind of jumps up when you go from independent living to assisted living. And maybe I'll start first with you, Larry, because I think it would be really helpful for everyone in the room to kind of hear your perspective, not just on the data, but on what you do, what your role is in senior living your organization as a whole.
Well, first of all, let me comment. I'm not particularly shocked by the data because it's kind of my life. As was mentioned, I'm a partner in Chicago Pacific Founders. We're a private equity firm based in Chicago and San Francisco. We're investing in a thesis based on the move from fee-for-service to pay-for-value, so that's part of our underlying philosophy, but also the aging population. And we touch this issue from a multitude of directions. First and foremost, under the leadership of my partner, John Rios, who's very active in this organization. But John delivers senior living services, independent assisted memory care, across 15 states. We have some 46 facilities that we own, another 14 that we manage. So we're experiencing this as an operator. Secondarily, we deliver direct primary care, at-risk primary care to Medicare populations through a provider group that we have based in Las Vegas called P3, another one in Tampa, Florida, and a third called WellBe Senior Care, which delivers primary care, fully capped for the most frail senior population. So that's another part of what we do. We also operate a Medicare Advantage plan, so we're in the Medicare Advantage business as well. And then last, we aren't technology investors, but we did invest with John Rios' encouragement in a company called IN2L, which delivers a technology platform that really supports the engagement of populations in memory care. So how do we improve the lives of people who are in memory care facilities? And so we kind of touch this from a number of different dimensions. And one of the things that's been particularly interesting about this conference is the disparate points of view of the attendees in this conference, and really understanding how we can all work more effectively together to impact this population. Because if we can deliver against this population effectively, we have a happier, healthier population that stays in the senior living facilities, and we don't see the churn. So if we can effectively service the needs of the population, it makes a big difference. But as people who are at risk for care delivery, that population, if we can keep them healthy, obviously we have very aligned incentives. So this is a really important topic for us, and I appreciate the opportunity to be here and learn more about how different entities are working to solve this problem for very different dimensions.
Oh, that's great.
Hi, Ken Sigarnik. I also want to say thank you, Anne, for inviting me to be on this panel and having the opportunity to work with you and Larry. You guys are both experts in your field, and you also bring such incredible insights. Brandywine Living is an owner-operator of assisted living and memory care communities, independent living in the Mid-Atlantic. We have 29 operating communities, and our 30th one is about to open in Potomac, Maryland. That'll be our 7th state of operation. We're headquartered just outside of Philadelphia. And as I look at these statistics, I'm also not super surprised by them, and I think I want to focus on a point that you made in your opening remarks. You took a moment to correct yourself and distinguish between the term acuity and frailty.
Yeah.
And I want to take a moment and just sort of think about that for a second, because acuity implies, a derivative of the word acute, which implies some sort of focused, concentrated need that's driven by an event. Could be a stroke or a cardiac event or something like that. Frailty is more of a part and parcel of the aging process. And what we've seen at Brandywine, we take care of 2,500 residents a day. And I would say, on average, you'll see a third to 40% of those residents turn over in the ordinary course every year. So we're touching the lives of 4,000 residents and their families throughout the course of every year. We've been in business for over 23 years. I've been with the company for 18. I'm a principal and the chief corporate officer. And I will say that this isn't like Darwinism, where we've seen, evolution occur over centuries. I've seen in a relatively short period of time an uptick in the age of the move-in of the resident, and I've seen an uptick in the frailty. And that shouldn't come as a surprise to the operators in the audience. What I find particularly opportunistic here is to benefit from Larry's insight is how you see this as being the investment environment from all sides of the horizon. These are the facts. They are not going anywhere. Yeah. And now we need to think about this session and about investment opportunity in the paradigm of this reality. The residents are moving in at an older age, and they're moving in at a higher level of frailty. So,
right.
That's interesting.
Yeah. So what you may also not be surprised to see is that this is a population that is also using a lot of healthcare. So just to take a really huge step back and pull up to the highest possible level, just in case you didn't know this, pretty much if you're serving the over age 65 population, then pretty much everybody who lives in your building is a Medicare beneficiary, right? And Medicare we're spending between every year it goes up so fast, I can't even keep track, $700 billion a year on this population, and the federal government's focus like a laser beam on how we can reduce per capita utilization, because which is basically a function of how much service use each person has and how much those service units cost. So that's their focus, because they can't do anything about the number of people that we're multiplying that by. So they're focused like a laser beam on that, and the primary strategy, I would say, or at least what I think is the primary strategy is to essentially ask the providers and insurance companies that operate in this country to take on some of the risk of this kind of growing healthcare liability that the government faces, right? So to your kind of like to Larry, the investment thesis is like we are looking, we are interested in investing in organizations that are contributing to, improving the value of what we deliver, which is about, a higher level of efficiency and a higher level of quality. And so these hospitalizations, so what you're seeing in this data are inpatient admission rates and emergency room visit rates. And these rates are, again, calculated for each of the populations that live in these different settings. And now I want to, I think maybe just to kind of bound this for you all a little bit, I want to just, so what do you mean by inpatient admission rate? So this is the rate at which, individuals go to the hospital or are admitted. And in the population that does not live in senior living, so this is everybody else, including healthy people, at the rate of hospital admissions is about 230 per 1,000, or 0.23. All right. At the far other end of the spectrum, long-stay nursing home residents, we're looking at a rate of about 680 per 1,000, or 0.68. So assisted living is substantially lower than nursing homes at 430 per 1,000. But one of the things that I find really interesting about the data is that the rate of ER visits is about the same. So what I would sort of surmise from that, or just sort of deduce, is that one of the challenges that assisted living facility providers face in particular is kind of that revolving door with the emergency room. Because what's happening is you're sending people to the emergency room as frequently as a nursing home, but fewer of them are actually being admitted for an inpatient stay. And that means that probably they're just being sent right back, or they're being admitted under observation or some other kind of mechanism. So this is, and I live near really, really just right down the road from an assisted living facility. And I will just report that there's a lot of ambulances kind of like revolving door kind of situation. And I interact with a lot of my friends who are now at the stage where their parents are in assisted living, and they talk all about how often their parents go to emergency rooms. So in another kind of just benchmark point, or something to just kind of keep in mind in terms of what's possible, is that Juniper Communities, and many of you are familiar with Lynn Katzman's work to integrate healthcare into housing model. She gets an inpatient admission rate of about 300 per 1,000. And her population is very frail in the kind of assisted living facility category. So I think I think assisted living is actually doing pretty well with inpatient admissions, really relatively speaking, given the frailty of the population. It could do better. And certainly when it comes to ER rates, there's also a lot of opportunity here. So Ken, I want to just kind of go directly to you, because I know that the reason I invited you to be on this panel is, that Brandywine is kind of aware of this phenomenon and doing things to address the rate of transfers to emergency rooms and the use of the hospital. And so I'd love to hear you talk a little bit about that.
Sure. I thought you invited me for my charm and charisma.
There was that too.
But, okay. whatever will do it. Yeah, I think, look, when you say that you have friends who are the adult children of residents in assisted living and they are experiencing visits to the ER, how many of them tell you that in a positive way?
Not any of them.
Not one, zero.
Yeah. Yep.
So I think we have to recognize that you'll have a whole constituency of people saying that the emergency room is the most expensive from a healthcare system and cost standpoint. It's the worst environment for someone to go to unless they absolutely truly need to be in the emergency room, and it's the last place people want them to go. And then you'll have the assisted living operators who would love to avoid an eventual inpatient hospitalization, which will sometimes ensue from an ER visit. But most importantly, from Brandywine's perspective, you have a consumer, the resident themselves and their adult child, who the last thing they want is to see, their loved one or themselves wind up in the emergency room. So we find that there's great opportunity to invest in the mechanisms that will help reduce reliance upon ER visits. Mm-hmm. And that investment for us, for example, includes 24-hour on-site nurses, third shift nurse on-site. Now, a lot of operators in this industry will have a third shift nurse on call and not on site. And the key difference between the two is a significant financial investment. Now, for us, and this can't be said for every operator in the business, but for us, our experience has been that many of the accidents that precipitate an ER visit happen in the middle of the night. A resident is, the things that you don't want to happen in the middle of the night. They get out of bed to go, use the facilities or something like that. They trip, they fall. And if you don't have a nurse on site to help coordinate the interaction with a physician, you may very well have no choice but to 911 the call. Mm-hmm. And I think the point that I want to emphasize is that there's a great alignment of interests between all the stakeholders here. And it's not just centered around the costs to the healthcare system. It's centered on delivering a significant value proposition, and a value proposition that can be passed along in terms of a private pay charge to the residents. This is not something that we give away at no additional cost. The cost of living in a Brandywine, because of our holistic value proposition, is going to be more expensive. Mm-hmm. And some people will choose to buy into that value proposition because they think these types of security and mitigants for going to the emergency department are worth the investment. And so that would be one example of an investment that we've made to try to reduce the impact of those statistics.
Yeah, let me come at it from a slightly different direction. I'm going to put my Medicare Advantage hat on for a second, and that of an at-risk provider. And also, I should disclose I don't want to say my bias, but the context. I'm from Southern California, the land of managed care, and the land of Medicare Advantage. But if you look at a typical Medicare population across all of these categories, you would typically experience about 1,500 days per thousand of hospital utilization. 1,500 days of hospital utilization. But if you look at days of hospital, yeah, okay, thank you. If you looked at a well-managed population, if you look at the stats for, say, Healthcare Partners in Southern California, that number's south of 800 days per thousand. So they are significantly, and by the way, the economic benefit to that group from managing the ER visits and managing the days per thousand can produce, between $2,000 and $3,000 of profitability per Medicare Advantage member. So highly profitable. So by effectively managing the population, they're demonstrably reducing savings and their participation in those savings. So one of the things that groups like Healthcare Partners and Monarch, which is another significant group in Southern California, who both coincidentally are now owned by United Health Group, which is another observation. But one of the things that they've been doing for years is they've been working closely with senior living in Southern California. So for example, Leisure World, no relation, Leisure World down in Laguna has a very close relationship with Monarch, which is the largest medical group there. And by working effectively with Monarch, Monarch and Leisure World, they've been able to effectively improve the care and the services to those senior members, but directly benefit from that increased coordination and lower cost. Leisure World in Laguna has a similar relationship with Healthcare Partners. And the result is better care, happier residents, demonstrably lower cost. A more current example of where that model is being applied is the Villages in Central Florida. I don't know, I assume everybody's familiar with it. It's 100,000 residents and 40 square miles. The Villages operate something called Villages Health, which is the equivalent of a Monarch or Healthcare Partners, but again brings accessible care, better coordination, and again realizes the benefits of that. So as we think about it as operators, we're both the senior living operator, but we're also the investor in delivering care to those communities. And we see lots of opportunities to do better care coordination, not necessarily delivering care in our senior living facilities, but improving care coordination, which will produce the benefits of both sides. If the the resident stays in the facility and does insure, and obviously that produces a real significant benefit to the operator. Likewise, the person who's responsible for managing the care, if they do an effective job in keeping them out of the hospital, they have happier, healthier, and more profitable members. So as we see this phenomenon, we see that there's going to become this better coordination on both sides, which will produce, I think, meaningful economic benefits for both parties.
And I just want to reiterate, I think Larry does an excellent job in identifying the Venn diagram of the overlapping interests between, let's say, in this case, the operator and the at-risk insurer. What's in the middle of that Venn diagram is the resident's interests. And the great news here, what's the great news here, though, is that the customer is totally aligned. The customer, this isn't a situation. I remember when my oldest child was born, this will date me a little bit, but like my wife and I tried to figure out a way that if she went to the hospital at a certain time, we'd get an extra day in the hospital. We were like, oh, it would be great if we
That
wanted.
didn't happen.
Yeah, right. We actually wanted to stay in the hospital another day, thinking that was the better, safer course of action. Times have changed. My son's not that old, okay? So, and neither am I, okay? But, times have changed. Staying in the hospital longer is not considered to be a protective benefit.
It's a very unhealthy place.
And so, so as a result, it's very important to recognize that there's a unique investment opportunity where not only does it align with the insurer's interests and the operator's interests in reducing costs and finding increased profitability, but it's exactly what the customer wants. And I want to keep that in mind as we think about the ways in which you're going to develop this investment thesis.
Yeah, and just to put further emphasis on that point, our company also runs an organization for caregivers called daughterhood.org. And we have so it's really valuable to us because we interact with the kind of basically the family caregivers of the folks that we're trying to improve the delivery and financing of care for. So, but I will tell you, like, one of the things we hear so often is when it comes to assisted living is sort of like, I'm paying $75,000 a year, I'm paying $60,000 a year, whatever it is, why am I at the ER so often? Or why am I still in charge of everything? Why is it my responsibility, essentially to kind of quarterback this very intensive set of care needs? And it's not fair to operators because these expectations are out of alignment. But to me, it points to an opportunity. And I think that whenever I give this talk or I evangelize on this in any way, shape, or form, I feel like I lose half the audience within 15 seconds because the presumption is that I'm suggesting that you should, Brandywine's made a big investment. I'm not necessarily suggesting that everybody has to go out and hire, an extra resource or, to take full responsibility for care coordination or figure out a way to pay for a nurse practitioner. It's really more about finding the organizations in your market potentially that you can align with who, like you said, have the same interests.
Right, and I think as we get deeper into your analysis here, we're going to probably end up thinking through, and everyone here is going to walk away with a sort of a wide array of models and mechanisms to accomplish the overarching objective. And some people are going to coalesce at the, look, I'm comfortable in this very low level of coordination and involvement and investment. I've got my hands full with just doing what I'm doing. And then you're going to have others like your Juniper partner who's going to say, look, I'm all in, okay?
Right.
And that's a different business too.
Right, it's a different business model. And I think people need to find where on the continuum they are. If I could just take one second as a footnote and put a plug in here for the NIC's Future Leaders Council has put together a survey that basically asks a series of questions. It's a very easy, user-friendly, interactive survey that asks a series of questions of basically where you would identify your organization, whether you're an assisted living, independent living, skilled nursing, whatever type of provider you are, where you would identify yourself on this continuum. And they're going to aggregate this data and they're going to share it as part of a published report. So if you're interested in taking the survey and you're an operator, please go to Senior Care Survey at nic.org and request a copy of the survey. Senior Care Survey at nic.org.
One more time, that's no.
I think Nick can only produce the data that it has access to. So if we could provide the data, they'll do some really interesting reporting on it. Okay.
Yeah. Great. So somebody is raising their hand, and I was going to say, oh, let's wait till the end and take questions, but no. But then I changed my mind. So why don't? Because this isn't such a huge group that we couldn't actually entertain questions as we go. So please.
ER visit numbers, and I think only assisted living and nursing homes have the option of losing their license if they fail to visit the ER. Similarly, yes, people hate going to the ER with their parents, but what they hate more is their parent not going to the ER when they need it.
I think that's a really, really, really important point. So consumers are fickle and tricky and hard to please because on the one hand, they're annoyed. On the other hand, they're relieved. Yeah, so no question about that.
Yeah, I just question, I think when somebody goes to the ER, frequently that's a failure. It's a failure in the system. So I don't disagree. Absolutely, when somebody needs to go to the ER, they go to the ER. But it's not stopping somebody going to the ER that should be going to the ER. It's understanding what the specific needs of that resident are, anticipating and avoiding the acute event that led to the ER visit. So,
or even in the event of an acute situation, not all of them necessitate an ER visit, and there are other mechanisms for coordination with physicians that would eliminate the need without the operator taking on the license risk of saying, I made this determination. A nurse can communicate with a physician. A physician can order, checks throughout the course of the night that may, at a minimum, defer the period of time for further assessment from the middle of the night to the morning. And that in and of itself starts to become a benefit for the families. So I absolutely think this gentleman makes a great point, though, that there is only so much risk tolerance that a licensed provider who doesn't have physicians on their staff can make. And so coordination in terms of making the decisions is a big distinction from ownership. Just because you coordinate with care doesn't mean you own the care. So you have to be careful about who you coordinate with and that sort of risk paradigm.
But I do want to just take this opportunity to say something about this setting that makes, and this is a good lead into kind of the next data point I'm going to show you, which is just that we've been talking about the opportunity here in the context of these are high rates, and if you bring them down, we can save money. But it's much easier, not easier, but it's much more efficient to address this kind of high utilization in the context of senior living, for multiple reasons, but mostly because the way you avoid an ER visit is that you notice a changing condition far in advance of it becoming, an urgent issue that requires that trip, just to kind of to Larry's point. And you're actually in a much better position to do that in assisted living than you are if somebody's in a single family dwelling, out in the suburbs somewhere living alone, unless they have great, remote patient monitoring and telehealth and, have a case manager and a nurse practitioner calling on them all the time, their likelihood is that they're going to go to the emergency room more often than if you apply a similar model in assisted living. So there's a lot of real value, and we'll emphasize this again as we go, but there's a lot of value sort of in this setting for organizations that might be, in fact, wanting to intervene to reduce these rates because it's a much kind of more, it's conducive to the intervention in a much more efficient way. So it's just a good segue to the kind of most exciting data finding, I think, exciting to me as a data geek, but which is that, so again, just kind of take a step back for those of you who aren't familiar with what Medicare Advantage is. So Medicare Advantage is an option for every single Medicare beneficiary for them to get their Medicare benefit, the Medicare benefits to which you were entitled under the law from a private insurance company. And you might be asking yourself, why would anybody ever choose to do that? And the very quick answer is that because it's much less expensive. Medicare fee-for-service has a lot of gaps. It has a lot of high cost sharing, and the only way to kind of fill those gaps and fill that cost sharing is to buy, private insurance, like fee-for-service insurance from Medicare supplemental insurance providers, and those premiums are high. Then you have to buy dental, then you have to buy, everything sort of has to be patched together, and it's expensive. Or you can go to a private insurer that's bundled it all up for you in the Medicare Advantage program. So because of the rising cost of healthcare and the rising kind of liability for these out-of-pocket costs, more and more people have been enrolling in Medicare Advantage. So compared to, and if anybody here operates a skilled nursing facility, you're like, I know. So, compared to 10 years ago, I think the Medicare Advantage penetration rate was 5 or 10%, and now it is almost 40% in the overall population, 40% depending on what data set you're using. And we expect it to continue to grow. I expect to see Medicare Advantage penetration rates of 50, 60% within the next 5 years. What I was shocked to learn is that the Medicare Advantage penetration rate in independent living and assisted living facility settings is actually only just slightly lower than the average in the overall population. It's coming in around 30%. That means 30% of residents in independent living, 30% of residents in assisted living are in fact enrolled today in a Medicare Advantage product of some kind. And, again, we fully expect that to increase as time goes on. So there are private insurers who are at risk for and paying for these hospitalizations. So United is making a payment to the hospital every single time your resident goes or to the ER. And there are, in fact, quite a few people enrolled in these plans in your buildings. So, so kind of here we are, kind of starting to see like these things start to come together. You're not necessarily, you're running a kind of a housing hospitality model on the one hand, but with a population that needs a lot of healthcare and is in fact enrolled in Medicare Advantage. So somebody's at risk for it.
Yeah, one thing I just comment is there's a lot of geographical variation.
Yes.
So for example, in California, these numbers are significantly higher. You look at Florida, they're significantly higher. And then there's also an aged phenomenon here is that the younger seniors have grown up in managed care, and many of them are just aging into these managed care plans. So they aren't necessarily electing, I want a Medicare Advantage plan. They're in Kaiser, they like Kaiser, they get to 65, they're enrolled in a Medicare Advantage plan. So we're going to see these numbers move up dramatically as they age in and become our residents. So we're going to see that phenomenon. The other thing is, as there's greater penetration, they're going to be outreaching through their at-risk provider groups, because all these Medicare Advantage plans contract with providers. Increasingly, the providers they contract with are these at-risk providers. And so as those numbers go up, they're going to be increasingly focused on reaching the patients wherever they are. So they're going to be finding you as senior living operators. They're going to say, how can we more effectively integrate with you and take advantage of the footprint you have? So, I mean, a lot of us are thinking about, well, how do we reach out to them? Don't worry, they're finding you. I mean, it's not surprising that there's people here in this conference from Humana and United Healthcare and others. It's because this is where the patients are. They see these numbers and they're looking for opportunities. They've also seen the case studies where by effectively integrating, coordinating, I guess I would use the term coordinating, not integrating, but better coordinating, they're achieving better results, and the operators are seeing the benefits, but they're seeing the very direct benefits from that integration. So I think this is a positive trend. I like the fact that they're at risk, because if that patient ends up using a lot of care because they aren't well managed, they get burned. Likewise, as operators, when you have people who you're losing to SNFs or you're losing them as residents, you lose. And so I like the fact there's very clear shared incentives to keep that patient population, your residents, happy, healthy, and out of the hospital and ER to the extent they can be. And if they need care, the worst thing you can do is defer care for a patient that needs care. So I know for a long time this fear that, these big HMOs like Kaiser's were denying care. That's the last thing they want to do, because all that does is exacerbate the problem. So I like the aligned incentives all the way around.
Yeah, no, definitely.
Look, I think it answers the age-old question that we used to ask at these conferences. Are we healthcare or are we hospitality? I mean, I think the answer is
yes,
resoundingly both. And if you were wondering whether or not you had a seat at the healthcare table, the table's coming to you. I mean, the data supports the fact that you have not only an increased frail population, but now you have more at-risk ancillary companies that are aligned with the infrastructure that we've created, which is a low-cost center for providing services and care. And they are very interested, as you said, they are at this conference. They're very interested in identifying ways to optimize everyone's interests, and I think it's a very significant reality. I think the fact that it's a Medicare Advantage population is an interesting statistic in terms of the evolution of the program itself, and I think that's a story that's still being written. But in terms of just what does an operator need to think about in terms of driving growth on its own at its own business, it's really not a question of how much risk you want to take on. It's really a question of how you're going to align yourself with those that are at risk. Because that's happening inside your system. So I'm not an advocate for becoming a risk-bearing entity, for a private pay senior housing operator becoming a risk-bearing entity. I'm an advocate for having eyes wide open for what's happening in the communities and all the stakeholders that are interested and involved.
Right.
One more comment about the Medicare Advantage players. It is interesting. They're pretty innovative. Centene, Humana, United, just to name three, are running all sorts of experiments.
Yeah.
So they're trying stuff and they're looking for partners. So how can we use telehealth more effectively? United's got a real interest in remote patient monitoring. There's things that we can do with passive monitoring. There's an example of something that United's been working closely with, which is a simple, it looks like a Band-Aid that you can just put on your chest here, and it'll measure respiration, heart rate, body temperature, 3D motion, and has a speaker. That's probably a little scary. Has a 6-week battery life. But the point is, doing something for a patient pre-post, this is not that funny, really.
Well, the Ken and you together.
I think it's neat. It's a lot not invasive. I think it's neat that that you have the benefit through your fund and your partnership with John. You have the benefit of sort of converging technologies and sort of, things that were developed without necessarily the purpose of implementation inside of a senior housing community, but just for the elderly population. And so this works anywhere, but what you're pointing out is something that is, potentially low invasiveness, high efficacy, could do a lot of different things. One, it could, enhance consumer outcomes and protective measures. Two, it could better align the infrastructure of a senior housing community with these at-risk companies. And three, there's probably a lot of embedded data opportunity that exists in the technology like this. So I'm not saying that, this is the first time I've seen this, that's why I was having a little fun with it. But I'm very well aware of these types of developments and how they're going to play a role in our ecosystem. Yeah,
actually, seeing John here, we met with the folks from Bose, for example, and they're developing some very low-profile things that allow you more effective hearing aids or hearing systems, and talking about doing it at a demonstrably lower price point, not $4,000, not $5,000, $400 or less. So, but bringing capabilities, technologies like that. So there's lots of those kinds of experiments that are going to be available, and if you're open to trying stuff in your facilities, there's lots of people who are going to be willing to do things or try things, and you don't have to jump all in. You can test these approaches.
But can I just make one comment about that? I think it's very important because when you're making the selection to partner with either a technology provider or a healthcare provider, or any selection that you make in partnership, brand is a very important component of this, because recognize that the population that we're servicing, this is their homes. We're not trying out technology in an institutional setting. You're doing it in their homes. So even the name Bose, it evokes a sense of high-end, luxury, and frankly, a residential product that most people here are accustomed to seeing in their homes. So if Bose can deliver a sound amplification system that really meaningfully makes an impact on the quality of residents' lives. And it's not, look, residents at any age, people are vain, right? They don't want to look like they're walking around with big cans on and things like that. If there's a way that they can do it that increases the quality of life, and you could align yourself with a brand like Bose, it makes a lot of sense.
Well, and I think so two things I want to emphasize on what you all just said. One is quality of life. I mean, a few years ago, when Nick first started doing kind of emphasizing this theme of collaboration in order to drive value in healthcare, we had this visualization where we had the kind of the resident in the middle. And you think about, we're not just talking about managing healthcare so that we can get a higher degree of value of healthcare. We're talking about, if you really want to have an engaged resident who's having a high quality of life, to to just sort of set healthcare aside as something just that's tangential to that is you're missing an opportunity to really, because quality of life is about health and wellness, and if you are the resident who's going to the emergency room every other day, you're not having a good quality of life. So, but the other thing I want to just kind of then flip back to something a little bit more sort of tactical here is, because we're getting ready to shift gears a little bit, and I just want to plant a seed in everybody's head. We were talking about Medicare Advantage plans, and one of you, maybe it was Larry, made this point about there are a lot of these plans are now delegating risk to provider groups. And this is just a really important point because you really do need, you may not necessarily have United Healthcare or Humana like traipsing into your building wanting a partnership, but they have essentially kind of delegated or deployed these physician groups like Caramore, like Optum, like, some Landmark Health, others to under subdelegated risk to essentially go out and find and manage high cost lives in a really efficient way. So that's sort of your connection point is through these, what we call, I'm going to use the term medical services organizations. You're going to see that term again in a minute. So anyway, I just wanted you to be thinking about this. It has a kind of a lot of dimensions to it, the way in which this is all going to come together and everyone's going to be kind of engaged and in partnership with each other. So kind of to that point, we in my firm, we've been working with a wide variety of organizations, including a couple of organizations that were interested in financial analysis around sort of what would it take to do to deliver in the community with private, with private houses, a model that is similar to what you could do in assisted living. So in other words, it's a clinic. How could we kind of create a clinic-based model with either has adult daycare or sends doctors into people's homes, and then create a Medicare Advantage, what we're calling an IE SNP in the community around all that. So it's not something that's actually been tried in nature yet, and they just want to do some financial analysis. Anyway, I'm saying all this just to say, one of the things that we learned pretty quickly was, it's really hard to stretch the premium dollar when you have to deliver services in individual family homes. And you don't have any other source of financing for any care services for those people at all. I think when I compare that financial analysis to the analyses that we do for iSNPs in senior living or nursing homes and the resources that we have to budget for, it's much lower. So we're budgeting for care management or budgeting for primary care. In the community, in the community setting, we've got to build a clinic. We've got to have office managers. We've got to have staff. This is on the right-hand side of the slide. There's like a very elaborate kind of web of support that has to revolve around that person and live in this kind of clinic setting in order to kind of make all that work. So I had this aha moment where I thought, golly, this is a lot of value that senior living is essentially delivering to the Optums and the Caramores and the United, because they can essentially kind of come in, have an enormous impact, perhaps some arbitrage impact that's already there just by virtue of the fact that the senior living services are there. They don't have to actually create a clinic. They've got eyes on these people all the time. They've got, care aides, nurses, and people, nutrition. It's all kind of built in. So I created this slide because I thought I just wanted to kind of tee this up for discussion in this context, and especially to get Larry and Ken's reaction to it. Because it got my mind thinking, are there ways in which there are NOI opportunities here above and beyond sort of your kind of the classic model that you're operating today? And so, Ken, I want you to react to that.
Sure, yeah.
Especially.
I think this is a great slide because it reinforces the fact that we have a very leverageable infrastructure. I'm talking about the senior housing communities. You could say the same for skilled nursing and for independent living, but I'm going to think specifically in the context of Brandywine. We've got a very leverageable infrastructure. Everything you said in terms of the wide array of services that are provided, the physical plant, the safety and security, the opportunities that sort of come in terms of how to align with the interest of the people who have chosen and trusted us with their safety and security, and those ancillary providers that work with them. I'm going to make a point about the industry at large that aligns with your point about the NOI. When you think about where we are today as an industry, Nick's going to report, Nick has been reporting occupancies across the assisted living industry in the mid to upper 80% range, right? So you're seeing 87, 88% occupancies being, considered to be today's norm. And some of that's actually after reporting, what people are hoping was the bottom, and now you're starting a slight uptick. It was only a few years ago that we would scoff at an upper 80% occupancy, and we were in the low 90s, and it was 91, 92% occupancy. And the difference, the delta between that 500 or 600 basis points of occupancy is huge for the operators in the room. And what has driven that? Well, there's a multitude of factors, but one of the things that we've seen is a lot of growth in new supply coming on, right? Everybody has been developing and a lot of new supply coming in. In the highest barrier to entry markets, there's a ton of supply coming in. And that has put a lot of pressure on operators. What I think operators need to do now is focus on ways to drive and optimize organic NOI growth. We're not going to be able to build ourselves out of this occupancy challenge. We're going to have to just focus on delivering a more diverse array of products and services and to find ways to leverage our infrastructure to be more relevant. And that means increased occupancy, and that means increased lengths of stay, and that means increased rates. And so when you think about this infrastructure as an operator, it's not enough just to focus on what we can do for these ancillary at-risk insurers or health systems, but also to think about ways in which it's going to help drive value organically at the community level, because it's incumbent on us to get ahead of this challenge that we're in right now.
Right.
Yeah. The only thing I was going to add, it's interesting as you talk about additional revenue streams, as you build a tighter coordinated model with the providers or provincially provider partners, I think there's an opportunity to collect a care coordination fee. I really think it's possible. I'm not talking about delivering care. I'm not suggesting the operators deliver care. I'm just saying to the extent that you create that integration point, not even integration, coordination point, I think there's an opportunity to monetize that value great, because to the extent that you are more effectively coordinated, there is going to be better care delivered to your residents. There's a value created. I think there's a value trade opportunity, and we're exploring that now with one of our companies to really push on that idea. But I think that could be. It would create an added incentive for you as operators to really think about doing that, because. To build it just on this notion that we think it'll drive these benefits. I mean, that would drive meaningful revenue now. So I think there's an opportunity.
Yeah, there is opportunity. I want to just emphasize again the details of some of the words that we're using, the differentiation. You used acuity and frailty earlier, and I honed in on that. And you keep purposefully using the word coordination. Yeah. And I think it's a very important word because I think it's differentiated from full-blown integration. Yeah. And it's also differentiated from what we've seen in this industry historically as co-location. Okay, it's somewhere sort of right in the center point. So let me sort of explain co-location. When you go to a Target, and you see Starbucks there, you have a fantastic co-location of amenities and services. And it inures to the benefit of the consumer. Trust me, my daughter will tell you, okay? She loves both the Target visit and, a venti latte. But the reality is that, for a long time, these two brands came together and said, hey, this is a leverageable big box environment and we could provide services. But that's all it is a co-location, and it's an amenity. What you're saying, Larry, and I think you're trending the same way, is what's the next step, a click above that, okay? And when we think about coordination, I want to explain what I hear as the distinction. I think if an operator, especially if you're going to charge a fee as a coordination of fee, I think there's great opportunity to provide value to the customers, a concierge level coordination of care. You mentioned earlier that one of the biggest struggles that adult children have is I pay all this money and yet I still feel like I'm at the vortex of all this healthcare administrative stuff. So there's a way to satisfy that burden. There's a way to monetize that and drive NOI growth. Equally as important is to be purposeful and intentional to find out what we can do to help drive more favorable outcomes to the resident. There's going to have to be a true investment. The person who's on the coordination team is not a ticket taker. That person has to be someone who's really invested in understanding what the services are, what the array of services that are being delivered, and how effective we are in delivering good quality outcomes.
Yeah, no, that's a really good point. Yeah.
Can I ask a question for Ken, actually? I had a question earlier, which I think you just answered, but I'm going to ask it in a different way.
Oh, you know what? So let me say this before you go further. So We'll have you ask this question, or we have a box for people to ask their questions into. Has everybody seen one of these before? They freak people out when it's their first time with one, but they're cool.
And if you don't get the right answer, you're going to whack us with it.
Exactly.
I get
And
so
so
through
I'll
it,
just,
exactly.
we have 2 more slides. We're just going to keep talking until we're supposed to be done. But if I would just want to invite everybody to ask questions from this point forward. So there you go.
Just because I have a clear understanding of how the Brandywine Living model works, is what you just described the way that you would bridge the selling proposition that you have now, which is a lifestyle, to being able to meet the innate healthcare needs of the population that is clearly going to be coming to your door? Because that's what it sounded like I heard.
Could be. I mean, I think, what I would say, Joe, in answer to your question is that there's been a high degree of stratification of the level of service that gets offered to this industry, whether you're in a primary market or a secondary or tertiary market, whether you're the Ritz-Carlton or you're the Hilton Garden Inn or you're the Motel 6. I mean, there's a broad array of different products and services that are available to the consumer today. As you know, Brandywine operates in markets and a model that's very high end. So the bridge that you're referring to, yes, I believe would be part of a concierge level type of service that I think would meet the needs of the customer, and they'd be willing to pay a part of the increased cost to have that added value proposition. For others, it may be a different type of bridge. It may be a bridge to stay very relevant to referral sources. It may be a bridge to align yourself with a single referral source, like co-locating with a hospital on campus. Or if you're in a secondary MSA, you may say it's the only way I'm going to get residents in here. So there's not a one size fits all answer to what that bridge looks like, but yes, it's a bridge.
And I don't think it has to be a bridge just for high end. I mean, in fact, if anything, I think we're going to, in the next 2 to 3 years, and I think even, Welltower is starting to hint at this already, which is, we're going to start to see experimentation with, housing that is more affordable, kind of in conjunction with Medicare Advantage products, which have a lot of flexibility to pay for a lot of things that are embedded in the rates for services that you all are already offering today. Transportation, med administration. Medicare Advantage plans can now pay for personal care services as a supplemental benefit. They can pay for all kinds of technology, care coordination, so lots of the things, meals. Medicare Advantage plans can pay for meals now.
And Welltower's model is doing that at a much more attainable price point.
Right.
So to your point, yeah.
Because you could start to begin to see some subsidization of some of those things that we would otherwise kind of drive through a private pay fee within the context of the Medicare Advantage premium, because of the opportunity to reduce hospitalizations to the point where you've created that room there. So if you can, we figured out a way to do it in the community in that model I was referring to earlier. You can definitely do it in senior living. And so we just put together the 3 of us kind of when we were on the phone prepping for this, we were sort of talking about, boil it down. There are kind of 4 kind of entities, stakeholders that have to kind of work together in some way, shape, or form to really drive the value that we're talking about. So it's that medical services organization I was referring to earlier, which is your primary care and case management and care management. There's the real estate itself, right? The fact that you have this building here, it's some entity taking healthcare risk, because only when you take healthcare risk, you actually have, essentially, do you create the flexibility in the funding source in order to pay for the enhanced primary care. So if you want to have a nurse practitioner answer a call at 8:00 on a Friday night, you have to pay that person differently than you could ever do under a fee-for-service Medicare. So Medicare Advantage creates that platform, essentially. And then, of course, technology, which enables really kind of all kinds of value enhancement in that setting and coordination of information and things like that. So, I think we talked about earlier today, at least trying to present a few more ideas of value opportunities. But before we do, I do want to take a quick pause and see if there's anybody else in the audience right now who wants to ask a question. I always find that the second I'm like, oh, okay, no one, oh, right, there you go. All right, well, we will, okay.
In the sort of, Ken, you in particular have tried to stress there are a lot of options for how you can play in this, so to speak, depending upon both the level of risk you want to take, all the way to, becoming your own plan. Do you own the medical services that are going to get provided in your building? Are you providing the real estate setting? So on and so forth. I guess the question I would have, because I think you both commented in essence that the healthcare plans are going to find you. They're going to come to you.
Right.
If that's the case, what would each of you say the senior care providers here need to do to get ready? In other words, what's going to make you a preferred provider versus why in the world would we want to work with you? We don't like your numbers at all, and we really want to go to your competitor across the street because, what we see in hospitalization rates or ED usage or whatever is so much lower. So I guess my question to each of you is, all right, maybe they're going to come knock on my door, but what do I have to do to be ready?
By the way, that's a really, really good question. And I thought a fair amount about it. One comment is, I think, and this is for Nick actually, is I think there's a real need to chronicle, to really build case studies. So what are the examples we can look to very specifically and see what's been successful? I know I've talked about Leisure World, I've talked about the villages. There's probably 20 or 30 use cases. And I think we really need to go deep on those use cases. What were the level of services? What was the level of integration? What were the economic benefits that were produced? How were they potentially shared? What are potential synergies that could be realized by better coordination with a senior living provider? I think we need to do some homework, because the worst thing you can do is guess. And I think the more evidence you have, the more you can point to specific examples, the far more compelling you're going to be as you just decide what you want to do based on the level of risk, as you mentioned, you want to undertake. And I think that that homework hasn't been done. I think at this session, it's been interesting. There's been several speakers talking very specifically to their model. Oak Street, I thought, did a really good job this morning. Juniper, the presentation, I thought was fabulous, but it didn't speak specifically. So, I worked with this senior living community in this way, with this level of integration or coordination, and this is how that worked, and this is what it entailed. This is the investment was made, and this are the returns. I think we got to do some homework. I mean, I think that when we know that, we'll be better informed. I think otherwise, it's fine if you just want to experiment, but not knowing the knowable seems kind of dumb from my perspective. So.
Well, and I think, I like Larry's comments. He's cautioning that you don't just, the operators don't have a ton of, free cash flow to invest in experimental measures. So you want people to be very pensive and look at models that may or may not have been successful. But Bob, I've got a slightly different answer, which may not be the one that is the most enjoyable to everybody. But this is, I think, an unavoidable truth in healthcare today. I think one thing that's missing from this slide, and one thing that addresses your question, Bob, is scale. The reality is that there is so much consolidation that's going on in healthcare in general, health systems, health insurers,
health plans,
that I think that if you intend on being a small boutique operator of a single, two communities, the answer may be different than if you're a scaled operator in a market, in a region. You don't necessarily have to be national, okay, but you have to have a brand platform and presence that I think is scalable and leverageable to meet the needs of a highly consolidating industry. Otherwise, I think you're going to be sort of nipping at it on the periphery, and that's going to alter the investment decisions that you're going to make.
Yeah, definitely agree with that. All right, we got another question here.
I got to come at this from a different angle. Your previous slide talked about having a medical practice with 200 covered lives down there at the bottom of it. All right. I'm from upstate New York, Rochester, New York. Heavy Medicare penetration, managed care at 70%. Wow. We have one payer in town, Blue Cross Blue Shield, that has 80+% of the market. They don't want to deal with any kind of provider association. We run everything from assisted living to skilled to independent housing. We own part of a medical practice. We miss the partner that's willing to take the risk. How do you attract somebody into a very complicated market that is willing to do that? So you mentioned earlier United Healthcare. Yes, they do the Optum program for the dual eligibles in the nursing home. They don't want to touch New York State because of the regulations on the assisted living side. Any advice? We need that payer to make our model work. It's costing us a fortune to run the medical practice, and we're only 2 years into it.
Yeah. Are you getting fee for service right now, or are you billing them on a fee for service basis?
We're just billing, but
they won't do a value-based contract with you?
There's no value in it. There's 2 hospital systems in town, and all of the primary care is attributed to them. So anyone that comes into any of our independent assisted living, they're already accounted for in a value-based product with one of the hospital systems.
How many lives are you serving today?
We have about 1,000.
Okay. So I have some ideas, which I'll talk to you about afterwards. Okay. But can I just take a quick step?
No, this is yours.
Okay, so this is a situation so I'd say this with a lot of, respect for what I'm about to say. Sounds really hard, but this is what you just described is the reason why there are, in fact, assisted living facility providers and nursing homes forming their own Medicare Advantage plans, because they simply cannot get the attention and the leverage that they need. And going back to that Optum product for just a minute, the Optum model was, we're going to go into a nursing home, we're going to bring our nurse practitioner. So Optum has the nurse practitioner. They're the medical services organization. United Healthcare has the Medicare Advantage plan. Optum takes the risk. Any money that they make, and they make a lot because they get that $680 per 1,000 down to $250 per 1,000 or something like that. All of those savings go right back into that medical services organization and weren't being shared at all with the nursing homes. Yeah. So what happened was the nursing homes got fed up and they started to form their own plans. And now the Optum model is starting to change. It's not easy. It's not fun. I will say there are probably more provider-led ISNPs in the state of New York than any other state in the country. And there may even be some that would be willing to let you kind of use their back office apparatus to offer their plan. So Hebrew Home in New York City has a great plan. There's a bunch of great providers doing really innovative things. And I would team up with them and just disenroll everybody in your buildings from Blue Cross Blue Shield and roll them in your product. And I'm making it sound simpler than it is, but yeah, that's what I recommend.
The translation Ann says, get a bigger hammer.
Yeah, you need more.
Hammer. You gotta leverage matters.
You gotta create your own. Get yourself to the top of the. Yeah.
Because related to that, there are examples in other states where when providers got together, all of a sudden gain sharing was
totally
100%. What a shock!
Yeah, they got the value-based contracts after they started to take lives.
One of the lessons of what's happened with healthcare payment reform is that nobody is going to voluntarily offer you part of the savings, period. And that's a total illusion.
By the way, there's 2 parts of it. One is you have to identify what the savings is. So you have to be able to measure. So what's the pie? And then you have to leverage. Then that's where leverage comes in. Well, how do we apportion the pie based on the value? Who's creating that value? But to your point, just identifying the value without leverage doesn't mean they're necessarily going to share it with you.
Well, I think a lot of operators, that's been a shock because they walked in to say, here's all the dollars I've saved you. And, the good news is, you can continue to be in our network. Yeah. But wait a second, I'm saving you all these dollars. You get rewarded.
We haven't
kicked you out of our network. Aren't you happy? And so the issue of leverage is a key issue.
It's huge.
And whether it's for-profit nursing home providers in Alabama, whether it's not-for-profits in a number of states like Ohio and so forth, either banding together or even just the threat that you're going to band together suddenly makes folks open up to the idea that maybe there's some way we can let you participate in this. But if you don't have leverage, they will never voluntarily move to do it.
Yep. And, I just want to say, because as soon as we start talking about forming a Medicare Advantage plan and getting involved in shared savings, I always feel like we lose half the audience. If one thing I would end on, I have 29 seconds, is that the theme is that this is, even just to have we could have a whole conference about this rather than just one session, which is that there are, getting back to your case study or use case, there are so many different ways to seize opportunities in the context of healthcare, whether it's but whether it's co-locating or,
Coordination
or
full integration.
Integration, owning some part of the risk, getting some part of the shared savings. There's really a kind of very wide variety of ways in which you can sort of participate in this. So, but leverage is a key part of how you make the decision about where you want to be. All right. Do we have any other burning, urgent questions okay. All right. Well, thank you very much for coming.
Thank you. That was good. Here, let me give you this.